Welcome to the fifth topic of 8 in section 3 of Unit 1, Pathophysiology of Common Injuries and Dysfunctions. In this tutorial we are going to cover fractures and some other conditions associated with the bones and nerves. Let's start with two quick pieces of information. Fractures and broken bones are the same thing, and as a massage therapist you are not going to massage over a fracture. There are various types of fractures. You have an open fracture. This is where the skin is broken and the bone may or may not protrude through the open wound. A closed fracture is where the skin remains intact. A complicated fracture is where there are issues or complications such as a bone fragment or end of bone damaging an internal organ. There is also a green stick fracture, mainly occurring in children as their bones are still soft. The fracture doesn't necessarily go all the way through the bone. It's called a green stick fracture because you get a similar result from trying to snap a fresh green stick. You rarely get two separate pieces, but often find lots of fibrous bits holding the two ends together. The most common causes of fractures are falls and extrinsic impacts. Signs and symptoms of fractures may include the client reporting hearing a snapping sound, significant pain. There may be some visual deformity and an inability to weight bear for lower limb fractures, swelling and bruising. They may also guard the area, so for example cradling the lower arm. Common bones to fracture are the clavicle, which is very common in cyclists, the scaphoid found in the hand, which is very common in sports where balls are caught, the radius, ulnar, tibia and fibula are all commonly broken bones. The navicular in the foot, this is usually a stress fracture rather than a fracture, and ribs are also very common. These also have a high risk of being a complicated fracture. Let's have a look at a couple of common fractures. First, there is the Pott's fracture. This is a fracture of either or both of the malleoli. The signs and symptoms are the same as any other fracture. There will be intense pain if they try to weight bear on the leg. This type of fracture can often be mistaken for a serious ligament sprain. Possible causes include an awkward landing, twisting or rolling the ankle, and a blow or impact to the lower ankle. These are very common in sports where jumping is involved. Next are vertebral issues. There are a variety of different types to consider. Vertebral end plate fractures are when the end plate is subject to excessive compressive forces that it cannot cope with. As we get older, the thin layer of hyaline cartilage that protects the vertebrae ossifies and becomes increasingly brittle, leaving the area less protected. It is very common for older people, athletes and very active people to have signs of wear and tear and imperfections, which can lead to greater risk of end plate fractures. You then have spondylolysis and spondylolisthesis. Spondylolysis is a term given to a defect in the neural arch, also known as pars interarticularis. There is a loss of bony integrity of the pars. It is possible to be asymptomatic with this condition, so there would be no signs and symptoms. But if there were signs and symptoms, they might be pain spreading across the lower back, worse with extension, feels a bit like a muscle strain. Spondylolisthesis is where one of the vertebrae slips forward. This can put pressure on nerves. As it is common at the fifth lumbar vertebrae, there is concerns that it will compress the cordia equina nerve, although rare. This is a bundle of nerves at the bottom of the spine that control the bowel and bladder and has serious implications. Again, this does not always cause signs and symptoms, but there could be pain in the lower back, eased when sitting or bending forward, tight hamstrings, pain, numbness and tingling down one leg. Both of these conditions potentially lead to stress fractures of the pars portion of the vertebrae. Next we have avulsion. This means to forcibly tear a structure away from a body part. It doesn't sound very pleasant, and it isn't. It takes a huge amount of force to do this. This is normally thought of as the tendon being forcibly torn away from its attachment point, and will more than likely take a bone fragment with it. If the full tendon comes away, then it and the muscle are likely to recoil. The signs and symptoms for this are potentially contracture, so shortening of the muscle or limb. There may be altered sensation, so tingling and numbness, for example. Obviously, there will be pain and swelling, and you may find a lump that is the recoiled tendon. If this is the case, there will be a dip or hollow where the tendon was. There will be a loss or reduction of movement as there is nothing attached to the muscle to move. The most common sites are the wrist flexors and extensors, which come about from trapping the hands or fingers in something and it being pulled sharply. So a good example for this might be a climber with their fingers caught in the rope as they drop or slip. These sorts of injuries require immediate medical attention, as the tendons need to be attached as soon as possible, or it may not be possible to stretch them back out and reattach them properly. Nerve damage. There are two main types here, neuropraxia and neurotomesis. Neurotomesis is the partial or complete severance of the nerve, disrupting its function. This will require medical attention and usually results in permanent nerve impairment. This is not one for the sports massage therapist to treat, and if suspected should be referred. There may also be underlying conditions. The symptoms are the same as neuropraxia, but extremely severe. Neuropraxia is the bruising or compression of a nerve without it causing permanent damage. Common neuropraxia would be the sciatic nerve being trapped by the piriformis, which can be resolved often fairly easily. It will be more problematic if it is trapped at the spinal column by a prolapsed disc, but can still be helped through physiotherapy. The most difficult is when it's trapped by the forearm, at the vertebrae. This is where the bone has started to grow, reducing the space available for the nerve. Painkilling injections may be tried, nerve blocks, or sometimes surgery is required. Carpal tunnel syndrome is another good example of neuropraxia. This is the impingement of the median nerve caused by the reduction in space of the carpal tunnel. This can be caused by inflammation of the structures of the carpal tunnel. The treatment for this can be massage of the muscles of the forearm, but unless it is very early stages, I've only ever really had temporary relief from this. Day or night splints to try and rest the area and allow inflammation to subside. You can then move on to steroid injections, and if all else fails, surgery. The retinaculum is cut to allow space. Nerves can be trapped or impinged anywhere, but these are a couple of the common ones. Signs and symptoms for neuropraxia are burning or shooting type pains, pins and needles, temporary weakness, numbness and paralysis. When the cause is removed, these symptoms go away, but that's not always that easy. If left untreated, then eventually muscle atrophy will occur to the affected muscles. There are various causes. Anything that causes inflammation around the nerve will likely affect it. Various forms of compression or impingement, such as muscles becoming too tight. Impact injuries can cause bruising and or inflammation and ischemia. Depending on the cause, the sports massage therapist may be of benefit quite early on, but you have to be sure it's muscular, and you have to go gently if the nerve has been trapped. It can become very sensitive and even hypersensitive. Dislocations. Many people get their medical guidance from Die Hard movies for dislocations, and I have seen someone try to put their own shoulder back in by smashing it against a wall in a nightclub. This is really not recommended. Dislocation is when a bone is totally displaced from its normal position. If it is a partial displacement, it is known as a subluxation. The signs and symptoms are extreme pain, the area will be visibly deformed at the joint, and you will have complete loss of function at the joint. Often people have regular issues with dislocations once it has happened, as structures such as the ligaments will be stretched and damaged. There are various potential causes. Some people are genetically predisposed. There may be a muscular imbalance, which causes instability by pulling too much in one direction. Extrinsic forces, training activities, and previous injuries can all be possible causes. Under no circumstances should anyone try and relocate the joint. This should only be carried out by medical professionals, as there is a risk of trapping nerves or blood vessels in the joint, which would be extremely dangerous and extremely painful. Next we have loose bodies. These are bits of detritus such as bone fragments, cartilage or meniscus floating around in a synovial joint. The normal causes of this are trauma or osteoarthritis, even extreme wear and tear. Signs and symptoms for this are locking, sticking or giving away of the joint, intermittent pain, often sharp, intermittent swelling and potential muscle atrophy. This is quite often managed with physiotherapy and potentially painkillers, but surgery is an option in the way of an arthroscopy, which can be used to remove floating objects and tidy up the joint. There is some suggestion now that wherever possible this should be avoided, as it can impact the life of the joint. There is little a sports massage therapist can do for the joint, but again they may be able to support the client with other issues such as compensatory problems. Shin splints is the generic term for a couple of conditions that you need to be able to distinguish between: medial tibial stress syndrome, MTSS, tibial stress fractures and compartment syndrome. Medial tibial stress syndrome is the inflammation of the periosteum. This is the membrane that covers the bone, and the issue is usually experienced on the posterior and medial surface of the tibia. The tibialis anterior, which is the cause of the problem, attaches along the tibia. The function of this muscle is dorsiflexion, which doesn't require the muscle to be overly powerful. However, the opposing muscles can end up being extremely strong or tight, or from injury become stuck to the bone, meaning the tibialis anterior has to work so much harder, potentially leading to MTSS. The opposing muscles would either be the soleus or the gastrocnemius. Signs and symptoms are a history consistent with the potential causes. There will be pain on the anterior and or posterior tibial borders. Inflammation will be present along the tibia, and there will be onset of persistent discomfort during activity, which will increase with running or walking. You will have limited dorsiflexion, and there will be pain on the medial border of the tibia. You will also have pain on full stretch or contraction, and you will find the foot is pronated. The possible causative factors are muscle imbalances, poor posture, overuse and too much too soon, but more than likely a combination of all of them. The next possibility is a tibial stress fracture. This is the microtrauma caused by repetitive impact forces, so the most obvious and common is running. The signs and symptoms for this are a history consistent with possible causes, pain felt on the anterior and posterior aspect of the tibia, onset or increased pain with activity levels, pain on palpation of the anterior aspect of the tibia, and nodules along the anterior tibia. This is felt in the chronic stage. The possible causative factors for tibial stress fractures are muscle imbalances, poor posture, poor footwear, overpronation, overuse or excessive repetition, too much too soon. Also poor diet, so being overweight but more likely being underweight and undernourished, leading to bone density issues. This is a common injury for female runners. If poor nutrition is involved, healing may be very slow, which will frustrate your client further, pushing them to exercise too soon. The third and final is compartment syndrome. This is the increase in pressure in any of the compartments of the lower leg, the foot, the arm or the hand, but is most common, and I've only ever seen it in the lower leg. It can appear to be very similar to deep vein thrombosis, DVT, when in the lower leg. You need to be confident that it's not DVT before continuing with treatment. There are two types of compartment syndrome, acute and chronic. Acute is a medical emergency. This comes on quickly, often associated with fractures or serious injuries, and can leave permanent damage if not treated quickly. Not one for the massage therapist. Chronic compartment syndrome is a slow onset condition, normally during exercise, and is not a medical emergency. The speed of onset is a good indicator to whether it's acute or chronic. Focusing on chronic compartment syndrome, the signs and symptoms are pain and swelling in the affected area, history consistent with the possible causes, the pain and discomfort will increase with activity, symptoms will then be relieved shortly after exercise has stopped. There will be pain on palpation and swelling and obvious bulking of the muscles. There will be pain on contraction and reduced range of movement. There may be neurological symptoms distal to the compartment, such as numbness and a reduced pulse in the foot. Possible causative factors are post-impact bleeding, so that would be the acute compartment syndrome. Less is known about the causes of chronic compartment syndrome, but it generally occurs in younger people who do a lot of repetitive activity, such as running and cycling. The leading theory is swelling of the muscles during exercise, affecting the blood supply to the whole muscle group. Treatment for chronic compartment syndrome is potentially change in exercise, physiotherapy, orthotics, non-steroidal anti-inflammatories, and as a last resort, surgery may be considered. It's clear you can't help with fractures and many of these conditions in the early stages, but once again you can help further down the line. Secondary compensatory patterns will be very common since areas are often immobile due to casts, or not being able to weight bear on them, or just too painful to use. Muscles will atrophy and other muscles will become overdeveloped. Now you've completed fractures and associated injuries, you can carry on and complete the quiz associated with this section. You can move on to the 6th topic, which covers a variety of injuries and dysfunctions.